Today I'm recording a history and physical for a 63-year-old male. He's being admitted inpatient to hospitalist service. Date of service is September 9th, 2014. The chief complaint is that the patient's wife called 911 stating that her husband was having trouble breathing and was not acting right. History of present illness is that this is a 63-year-old male. He has a history of COPD, coronary artery disease, cabbage times 3 vessels in 2012, hypertension, and diabetes. He was sitting at home this evening and his wife noticed that he was not breathing very well and was not acting right. Said he was obtunded. EMS was called to the home where they noticed the patient was having a hard time breathing with a peripheral oxygen saturation of 79% on 2 liters nasal cannula. Breathing treatment was given via nebulizer with albuterol, and high-flow oxygen therapy was started at 15 liters, 100% non-rebreather. Upon arrival to the ER, his oxygen saturation had improved to 86%. They drew some blood gases in the emergency room, which were pH of 7.2, PCO2 of 109, PO2 of 52, bicarb of 25. The patient was placed on BiPAP with settings 15/7 and FiO2 of 100%. His chest x-ray showed bilateral basilar infiltrates, and his vitals in the emergency room were a blood pressure of 100/65, pulse of 108, respiratory rate of 26, and oxygen saturation of 96% on the BiPAP. The patient was febrile with a temperature of 102.3 degrees Fahrenheit. Blood, sputum, and urine cultures were collected, and vancomycin 1 gram was given in the emergency room. The patient has a significant medical history for COPD, diabetes, hypertension, and coronary artery disease. His only surgical history is the triple bypass in 2012. Home medications include lisinopril 20 milligrams daily, glyburide 5 milligrams daily, Spiriva 18 micrograms daily, prednisone 5 milligrams twice daily. The patient also has a duoneb treatment via nebulizer every 4 hours as needed for shortness of breath at home. The patient is allergic to penicillin and contrast dye, IV contrast dye, which cause a rash. Social history is that the patient lives at home with his wife. They have home health care that comes into the home 3 times per week. He uses a walker to get around in the house and is on HOMO2 at 2 liters per minute continuous for COPD. The patient doesn't drive and his wife is also in poor health, so they depend on their brother, the patient's brother, to help them get from place to place. The family history is significant on his mother. She is deceased and she has positive health history for diabetes, hypertension, and coronary artery disease. She died in 2011 from a heart attack. The patient's father is also deceased and has a history of dementia. The patient does receive his yearly immunizations. His flu and pneumonia are currently up to date. Upon review system, the patient's eyes appear normal. He denies any vision changes, glaucoma. He does report wearing reading glasses while he reads. The patient denies any ringing in his ears or hearing loss. He does not have any pain in his ears or vertigo. The patient's nose, he denies any difficulty smelling or sinus issues. He does report a scant amount of clear nasal discharge over the last week. The patient denies any soreness in his throat or pain in his throat or neck. He denies a history of TMJ and denies any difficulty swallowing. Neurologically, the patient denies confusion, dizziness, or memory loss. He does report feeling more fatigued over the last week than usual, but the wife does report that he was confused earlier and obtunded, not acting himself. Respiratory, the patient reports a history of COPD. He does report having a cough times 1 week and worsening shortness of breath despite his nebulizer treatments. He reports increasing intolerance of ADLs due to his shortness of breath as well. Cardiac history, he does report triple bypass in 2012 after ER visit for chest pain. The patient does deny any recent chest pain or heaviness. He denies any blackouts, palpitations, peripheral edema, DVTs, or irregular heartbeats. Gastrointestinal system is intact. The patient denies abdominal pain, nausea, or vomiting. He does not have diarrhea or constipation. He does not have a history of hepatitis or GI bleed. He does report regular bowel movements, the last of which was yesterday. He does report a recent history of decreased appetite from not feeling well within the last week. Genitourinary system, the patient denies any pain with urination or blood in the urine, denies frequency and urgency. Musculoskeletal, the patient reports decreased strength over approximately the last week. He denies osteoarthritis, rheumatoid arthritis, swollen joints, or neck pain. His skin is intact. He denies a history of eczema, dermatitis, or acne. The patient was a 3-pack per day smoker times 25 years and quit when he was diagnosed with COPD 25 years ago. His physical exam. The patient's vitals are as follows: blood pressure 100/65, pulse 108, respiratory rate of 26, oxygen saturation of 96% on BiPAP. The BiPAP settings are 15/7, FiO2 100%, and the temperature was 102.3. Tylenol 1,000 milligrams has been given for the patient's fever. The patient's general appearance is that he is an obviously ill Caucasian male. He appears to be normal weight and height and is developmentally appropriate. He is lying supine in the hospital bed, and conversation is muffled due to the BiPAP mask, but the patient is more alert at this time than previously reported and conversing appropriately despite the BiPAP mask. The patient's head appears normal, round, without malformation or trauma. His facial expressions are also symmetrical bilaterally. The patient's pupils are equal, round, and reactive to light and accommodation bilaterally. They are 3 millimeters bilaterally. His eyes are not red. They appear free of drainage. There is no tenderness to palpation. His ears appear symmetrical bilaterally with no deformity noted. The inner ear canals are without redness or drainage. The tympanic membranes are intact, pearly gray with landmarks and cone of light visualized bilaterally. There is no nasal redness, though scant clear drainage is noted. The neck is supple without swelling. Nodes are intact with normal limits during palpation. The throat is clear with no redness or exudate noted. No JVD is noted. Respiratory status, the patient has experienced dyspnea at rest. Lungs are coarse bilaterally and diminished at the basis bilaterally. Initial ABGs have improved. They have been redrawn 1 hour after BiPAP has been placed. His new pH is 7.32, PCO2 is 60, PO2 is 82, and bicarb is 27. He is also more alert than he previously was. Cardiac status, the patient's blood pressure is 100/65, pulse is 108 with regular rate and rhythm. S1 and S2 are present with no gallops noted, no murmurs, and no rubs present. Capillary refill is less than 2 seconds in bilateral extremities. Gastrointestinal status is intact. Patient's abdomen is soft, non-tender, and flat. Bowel sounds are present and normal active in all 4 quadrants. No mass is felt with palpation. No rebound tenderness or guarding is noted. The patient denies any pain or bleeding with urination as well. Musculoskeletal system. The patient has no noted kyphosis or scoliosis, though further evaluation would be best with the patient standing. Decreased muscle tone is noted due to recent illness. Neurologically, the patient is currently intact. All cranial nerves are intact. Sensation to light touch is intact bilaterally. Deep tendon reflexes are intact bilaterally. Grips are equal bilaterally but weak due to recent illness. He is currently awake and alert, oriented to person and place. Patient was reoriented to purpose of hospitalization as he does not remember any of the day's earlier events. Laboratory and radiological findings are as follows. White blood cell count of 30.2. Hemoglobin and hematocrit are stable at 12/35. Procalcitonin is elevated at 7.2. Sodium is 136. Potassium is 4.6. BUN is 24 and creatinine is slightly elevated at 1.6. Post 1 hour BiPAP ABGs are improving. pH 7.32, PCO2 of 60, PO2 is 82, and bicarb is 27. Glucose level was 98. The patient's chest X-ray is significant for bilateral hilar fullness and bilateral lower lobe infiltrates. Diagnosis are as follows. Primary diagnosis is bilateral lower lobe pneumonia, community acquired. Number 2, sepsis. Number 3, acute respiratory failure with hypoxia. Number 4, COPD exacerbation secondary to pneumonia. Number 5, coronary artery disease with a history of bypass graft. Number 6, diabetes mellitus controlled with glyburide. Number 7, hypertension controlled with lisinopril. The plan for admission is that the patient will be admitted inpatient to the services of the hospitalist group. He is being admitted to the medical floor, room 256. I've continued BiPAP on the current settings throughout the night and will redraw ABGs in the morning. I've ordered oral care every 4 hours and as needed. Nursing is to keep the patient sats greater than 92% at all times. I've ordered breathing treatments with Duoneb every 4 hours and as needed for shortness of breath. I'm going to start the patient on Solumedrol, 125 milligrams IV every 6 hours. Protonix, 40 milligrams IV daily for GI prophylaxis, and Lovenox, 40 milligrams sub-Q daily for DVT prophylaxis. I'll be covering the patient with broad-spectrum antibiotics until cultures are returned. He will be on vancomycin 1 gram IV piggyback every 12 hours. Levaquin, 750 milligrams IV piggyback daily. Marin, 100 milligrams IV piggyback Q6 hours. The patient's maintenance IV fluids will be normal saline at 100 cc's per hour. Fingerstick blood sugars will be every 6 hours. I will resume the patient's home medications once it's established that he can tolerate PO intake and medication administration. The patient will be kept on strict INO every 4 hours. I would like to keep his blood pressure greater than 100 and his MAP greater than 65. I've ordered serial daily labs of ABG, CBC with differential, CMP, CRP, and procalcitonin for the next 3 days. Also, I will follow the blood, sputum, and urine cultures for final culture and adjust antibiotics accordingly. I've ordered a chest x-ray in the morning to compare to today's and see if the patient is improving. Also, the patient will be a full code.